First of all, I'd like to thank Professor Dr. Khaled Abdelkarim for his kind invitation to me to be here with you. And my lecture will be about technical advances and the future directions in radical radiotherapy of lung cancer. Lung cancer remains the second common cancer and is fatal in about 70 to 80% of cases. Only 21% of all patients with lung cancer are alive 5 years or more after diagnosis. Much progress has been made recently for lung cancer, such as screening, minimally invasive techniques for diagnosis and treatment, advances in radiation oncology, new targeted therapies, and new immunotherapies. This progress was reflected in the improved survival rates. Role of radiotherapy in both small cell and non-small cell lung cancer is increasing in most of patient stages as radical, adjuvant, and palliative cases. Different radiation protocols are used. Radical stereotactic ablative radiotherapy is used in stage 1 non-small cell lung cancer, and definitive radiotherapy in stage 1B, 2, and 3A non-small cell lung cancer. Adjuvant radiotherapy after surgery in stage 1B, 2, and 3A non-small cell lung cancer. Definitive concurrent chemoradiation in stage 3B non-small cell lung cancer. Palliative radiotherapy in stage 4 non-small cell lung cancer, and sometimes radical in recurrent and oligometastatic disease. Radical SBRT and adjuvant radiotherapy in limited stage small cell lung cancer. Definitive concurrent chemoradiation in limited stage 2 and 3 small cell lung cancer. And palliative radiotherapy in extensive stage small cell lung cancer. Over many years, radiotherapy techniques have been improved. The aim of advanced techniques is to apply higher homogeneous dose to the target volume, increasing local control and survival, with optimal sparing of the surrounding normal tissues, decreasing side effects, so to improve the therapeutic ratio. Technical advances and future directions in lung radiotherapy include advanced planning solutions as IMRT, VMAT, and proton beam, incorporation of PET-CT in radiation planning process, increasing use of SBRT in early stage non-small cell lung cancer, use of 4D CT to account for tumor motion, tumor gating and tracking, IGRT to limit PTV margins, adaptive radiotherapy, MRI-based LINAC, and machine intelligence for immediate adaptive planning. Due to its dosimetric advantage over 3D conformal radiotherapy, both IMRT and VMAT are now used as standard techniques for radical radiotherapy. In comparison to 3D conformal radiotherapy, IMRT has been proved to produce lower rates of severe pneumonitis and cardiac doses. Retrospective data suggests that radiation therapy with protons may be associated with superior survival compared with standard radiation in non-small cell lung cancer, and a phase 2 trial showed similar results between passively scattered protons and IMRT. A Mayo Clinic study of 79 patients demonstrated similar overall survival, disease-free survival, and freedom from locoregional recurrence in patients treated with proton versus IMRT at 1 year. These data suggest that proton therapy may be an effective and tolerable alternative to standard radiotherapy in unresectable stage 3 non-small cell lung cancer. In addition to GTV, CTV, and PTV, ICRU 62 report has identified internal target volume ITV. GTV should be contoured using lung window, and the mediastinal window is suitable for delineation of mediastinal lymph nodes and chest wall tumors. CTV margin should be added to account for areas at risk of microscopic disease, and no CTV margin for SBRT. ITV is generated by tumor delineation in all phases of respiration. PTV margin is added for setup errors. For radical radiotherapy, the standard fractionation schedule remains 60 gray in 30 daily fractions. However, many other protocols are being used. The proximity of lung tumors to critical thoracic structures requires that the high dose of SBRT to be delivered accurately and precisely to minimize normal tissue exposure. SBRT requires reliable patient immobilization, daily imaging for accurate repositioning, use of multiple treatment fields, and a method accounting for tumor motion during treatment. SBRT is an alternative as primary treatment for patients with early stage non-small cell lung cancer who are not candidate or refusing surgery. In a phase 3 randomized trial comparing SBRT with conventional fractionated radiotherapy in patients who are not candidate for surgery, SBRT was associated with improved local control and overall survival after 3 years. For SBRT, many dose regimens are used according to lesion size, location, and its proximity to the chest wall. Special tables of organ at risk dose tolerance are followed during planning process. PET-CT-based tumor delineation has increased the accuracy of tumor identification. The use of PET-CT in planning led to about 35% change in stage definition, target volume change in 60% of cases, reduced variability in GTV delineation between observers. PET-CT can detect metastases in about 10 to 15 of the surgical candidates. The main challenge is organ motion. Respiratory motion can be a disadvantage as in lung cancer. During respiration, the target is moving, increasing margins, so irradiated normal tissue volume increases. Lung lesions near the diaphragm may move up to 4 centimeters with respiration, and respiratory motion can be an advantage, as in breast cancer by deep breathing, separating the target from the heart and lung. 4 main strategies are used to reduce the effect of respiratory motion. Integration of respiratory motion into treatment planning, leading to individualized margins. Reduction of the breathing motion by immobilizing the target lesion by compression techniques. Respiratory gating techniques, so radiotherapy is given during specific respiratory gates only. Tracking technique as the treatment beam is moving with the breathing motion of the tumor. To integrate respiratory movement into planning, 4DCT obtains images during different phases of the breathing cycle, apply geometric margin taking into account the motion to create ITV. Advantage is better tumor control, but the disadvantage is larger irradiated volume. Immobilization by abdominal compression and ORFID in patient receiving SBRT for lower lung lesions can reduce organ motion. Gating is irradiation in limited phases of respiratory cycle in a mobile target. CT images are acquired during a specific gait or amplitude, and the patient is treated in this gait or amplitude. Gating can be prospective or retrospective scanning. Prospective method is to determine the gating window before scanning. Retrospective method, CT images are taken while the patient is breathing freely. However, treatment is taken only in selected parts of the breathing cycle. Breath hold is done every session at the same respiratory phase, generally done in deep inspiration. Techniques can be used as passive techniques in patient voluntary breath holds as RPM, real-time position management, and infrared body surface gating, and active techniques as ABC, active breathing control. A valve temporarily blocks the airflow of the patient. In ABC, the patient is coached to hold the breath in inspiration, and the treatment is delivered only in this state. About 1 to 2 breath holds are needed for the CT scan during planning, and about 4 to 6 breath holds are needed to complete the treatment session. The disadvantage is compliance, as only limited number of patients can tolerate. Breath hold technique using surface scanning by sensors as catalyst can be more convenient to the patient. The respiratory gating is aided by internal surrogate as implanted radio-opaque fiducial markers as gold markers. It is invasive but more accurate. And external surrogate as RPM and surface infrared gating. It is non-invasive with good compliance but less accurate, and there is uncertainty in the correlation between the tumor position and the external monitor. Gating window is the range of the surrogate signal, and the beam is delivered only when the signal is situated within this gate. Beam on within gating window and beam off outside the gating window. The gating window for an external surrogate is defined by either amplitude or phase gating. The duty cycle is the ratio between beam on time and the total treatment time. Non-gated treatment means that the duty cycle is 100%. Gated treatment means the duty cycle 30 to 50%. The larger the gating window, the higher the duty cycle. Tracking solves the problem of tumor motion during respiratory session. Imaging is used to track the actual tumor motion during treatment and to move the beam accordingly based on the varying position of the tumor. Real-time tumor tracking can be done using external fiducial markers on the skin surface or by internal fiducial markers implanted directly in the tumor and detected by fluoroscopy-based solution. Robotic system as CyberKnife can deliver image field guided frameless SRS. Two X-ray tubes are placed in the ceiling with two opposite detectors in the floor. The acquired images are compared with the treatment planning CT scans to confirm the target location. Use of 6-degree couch can correct the setup errors, including rotational errors before and during treatment. It is used in conjunction with real-time tracking to align the patient with the highest accuracy. IGRT is the use of imaging techniques before and during radiotherapy to help localization of the target, to reduce the tumor motion, and to adapt the treatment to reduce the interfraction motion as patient positioning, tumor response and organ motion, and the intrafraction motion as breathing motion. Many tumors change in size and shape during the course of radiotherapy, so IGRT can solve the problem results from such a change. IGRT describes a chain rather than a single process. It leads to an action that improves the setup accuracy. So imaging plus radiation therapy equal IGRT. Portal imaging including KV, MV, COM-beam CT and MVCT matching with the CT planning are used to reduce the setup errors. Treatment verification using KV X-ray imager is used to do plain image or COM-beam CT. MV EPIT is used to do an image in the treatment position. KV images have better contrast than MV images. So IGRT refers to a process to reposition the patient without modifying the initial treatment plan. But adaptive radiotherapy involves the modification of the initial plan to a new plan with the new target. However, adaptive radiotherapy depends totally on IGRT. So IGRT supports adaptive radiotherapy success. Adaptive radiotherapy is defined as changing the treatment plan during radiotherapy course to account for the changes in the anatomy, as tumor shrinkage, weight loss, or internal motion. It enables the modification of the treatment plan using anatomical information acquired over the treatment course. Studies that evaluated the role of adaptive radiotherapy in lung cancer concluded that there is reduced toxicity while improving tumor dose coverage by adapting plans at mid-treatment. Components of adaptive radiotherapy are image acquisition, both online and offline, and its frequency depends on the technical details of the case and the expected clinical scenario. Then recontouring of both target and organs at risk, replanning with planned sum of original and modified plans, and then decision making of adaptation, which can be taken as the institute protocol, for example, after 20 to 40 grays, or based on the clinical observation as non-fitting mask, weight loss, or significant change in tumor size. The patient selection for the greatest benefit from adaptation has no uniform consensus. For patients with non-small cell lung cancer, initial plans were suggested to be modified if the tumor regression is about 30% within the first 20 sessions. With a single adaptation at mid-treatment, about 65% of the potential dose escalation can be achieved. Replanning twice at week 2 and 4 may achieve an average escalation of 12 grays. Since tumor shrinkage depends on many factors such as tumor histology, location, stage, and the imaging modality used, the optimal time for plan adaptation could be different for individualized patients. In a study, a total of 158 MVCT images were performed on 7 lung cancer patients. GTV was reduced by 60 to 80% during the course of treatment. The absolute volume of ipsilateral lung V20 can be reduced between 17 and 23% by adapting the treatment plan. So adaptive radiotherapy is now more successful due to increasing use of MR imaging on board, advances in imaging reconstruction for cone beam CT generating high quality images, enabling 4D cone beam CT and breath hold CT and artifact reduction, the use of cone beam CT in dose calculation and the plan modification, and the advances in motion management solution. Machine intelligence is the ability to do plan optimization with high speed and accuracy in correlation to change in anatomy over time, making adaptive radiotherapy a continuous process, as ESOS machined by a Varian medical system. MR-Linac can make solution for motion management by daily on-board MRI-based matching and adaptive therapy. It has the following advantage: superior soft tissue contrast, providing higher accuracy. IMRT can be performed, plan can be performed in only 30 to 50 minutes, so it has been used in real-time adaptive therapy. No need for fiducial marker placement, thus reducing cost and burden, and no metallic artifact as in CT. But it has the following disadvantage: limited field of view and field size, time-consuming treatment sessions, a limited pool of standard immobilization devices, inability to treat patients with implants, metallic, and the cardiac devices. Currently, 1 photon energy only is available, 6 MV, more expensive than ordinary Linac, and needs highly trained staff. Take-home message: use of PET-CT in delineation process is of great benefit. The new advanced techniques and the machines allowed SBRT dose escalation to a therapeutic level comparable with surgery. Organ motion is the main challenge. However, newly developed technical solutions are now helpful. IGRT is an integral part of any conformal radiotherapy plan for lung cancer. Consider adaptive radiotherapy whenever possible to improve the therapeutic ratio. Machine artificial intelligence and MR-based Linac are the future trends. Well-trained doctors, physicists, and technicians should work in a team for proper implementation and commissioning of all recent advanced techniques. Thank you.
Thank you, Professor Ihab, for the elegant lecture. Any questions?
I'm a lecturer in Ain Shams University, Cairo, Egypt. So my question is, what do you think an alternative for the 4D simulation, for the IGRT, as you know that we have no availability of these machines here in Egypt, in many institutions, especially our university institutions, do not have this advanced technology of 4D simulation, IGRTs, and gating. So what do you think would be an alternative to avoid any geometric mass of the tumor?
Okay, the first message is whenever you have gating or 4DCT, please go for it if the patient is indicated, okay? If you don't have 4DCT or gating or this technique or tracking, try to use the other techniques. Try to use higher advanced techniques like MRT, VMAT, instead of 3D conformal radiotherapy. Try to do PET, to involve the PET in delineation process. Try to do adaptive radiotherapy whenever you can. And then you can get the maximum you have. And really, in our practice, not all patients, if you already have 4DCT, not all patients we are treating in this technique.
That's true.
We have, whenever the lesion is near the diaphragm or near the chest wall, we can need this technique. However, in some of central tumors, with less motion, less than 1 centimeter up and down, we don't use it. So even if we have the technique, we should select the patient to give such technique. We have already limited resources and the crowded patient, the high number of patients on machine. So we have to limit your resources to your patient who is indicated already.
Thank you, Professor.
Thank you.
Thank you, Professor Ihab. We will end the session for the
Thank
sake
you
of
so
time.
much. And we are concluding the session. We are shifting exactly to save time because we are a little bit late. But Dr. Ihab, Dr. Lopez, Dr. Amin, Dr. Khalid Shahat, thank you so much. We will shift directly, but allow us for 3 minutes. Everyone is having the lunch card to drop the lunch while we are continuing, please, for the coming 2 minutes. Thank you for attending our conference. Thank you so much.